Good morning, everyone, and welcome to Meds Ed, the ongoing primary care education series sponsored by CareOregon and CareOregon's pharmacy department. I want to also briefly mention, if you look at this introductory slide here, in addition to it telling you the content you're being treated to this morning, there's also a chance to enroll in our next upcoming session that will be in September, where we focus on health literacy and the concept of numeracy. Very often we're trying to convey a lot of complex information to patients in understandable terms. And I think that there can sometimes be a perception that healthcare is like an unruly box of IKEA assembly instructions from the perspective of the patient. And so we've got some phenomenal folks lined up for that session coming on in the fall to help us understand about numeracy and health literacy in more digestible terms. So it should be a great session. Enrollment is open for that and now, so you can certainly share that link and get involved and make sure that you don't miss out. But today's session is something else entirely. Today we are focusing on advances in heart failure treatment. Timing's always a little approximate with a live event, but we're going to be having Dr. Josh Remick lead us off today. And then we have co-presenters for our second segment from Oregon Health Science University. And then one of our own pharmacists, Jason Malari, is going to be conducting us through some of the most up-to-date information as far as how to navigate best practices to making sure you're getting those medications. So I'm sure you will have lots of questions. Here's a snapshot of all the different learning objectives that our content covers today, from understanding the scope of the heart failure epidemic to barriers of initiation and the relationship between methamphetamine and cardiomyopathy, which is something that doesn't get nearly enough exposure in terms of awareness. Real quick, before I introduce our main presenter here today, I want to just mention the last time that we presented on heart failure here at MedZed in CareOregon was back in 2017. That's over 6 years ago. And at that time, there were really comparatively narrow medication options for treatment when you hold it up against what's available now. Since that time, options for effective medication treatments have frankly greatly expanded. New medications are now available, resources that help reduce hospital visits and deaths from heart failure. We're also going to take a look, as I mentioned, at the relationship between methamphetamine-induced cardiomyopathy and the risk of increase in readmission for this population. So a lot of things that just don't get enough exposure or as much realization. I think during the pandemic, a lot of folks' attention was fixed elsewhere. And a lot of times folks just weren't even conscious of the fact that all these new treatment options had become available. So this is a chance to really get up to speed in terms of the most current and effective resources available for our patients and our members on heart failure. So I think you're in for a great morning, a lot of really super practical, impactful information. I'd like to go ahead and kick us off by introducing our first presenter. Dr. Joshua Remick is a cardiologist with extensive experience in advanced heart failure and transplant cardiology, nuclear medicine, and adult cardiology. He graduated from Albert Einstein College of Medicine at Yeshiva University in 2005 and completed an internship and residency at New York University School of Medicine in New York, where he served as chief resident. He went on to complete a cardiology fellowship at Emory School of Medicine in Atlanta and received additional training in advanced heart failure and transplantation. In his practice, Dr. Remick believes his most important role as a cardiologist is to educate his patients so they can make informed, intelligent healthcare decisions. He's going to share that same kind of emphasis on education with us here this morning. I also understand Dr. Remick is a passionate hockey fan. So maybe, if we're lucky, we can get him to persuade him to reveal who his favorite hockey team is, because that's a sport that'll put your heart through the ringer, if you know what I'm saying. So please join me in welcoming Dr. Josh Remick.
Thank you, Paul, for that lovely introduction. Just before I get started, just want to make sure everybody can hear me and see me okay and see my slides.
You sound and look great.
Perfect. Excellent. So thank you all for joining us this morning. As Paul mentioned, I'm a heart failure cardiologist with the Providence Heart Institute up in Portland, based primarily out of St. Vincent Hospital, but I do see patients over at our Hollywood clinic and at Providence Portland Medical Center as well. I'm going to go through a fair amount of information today, and what I'm really hoping is to kind of describe the scope of the heart failure epidemic to you guys, focus a decent amount on updates to medical management, both for systolic heart failure, known as heart failure with reduced ejection fraction, and sort of diastolic heart failure, also known as heart failure with preserved ejection fraction. I'm going to try and give you some clinical pearls for assessing and monitoring patients with heart failure. And I'm also going to touch on signs and symptoms that suggest advanced heart failure disease, sort of progression of the disease to a stage where really we need to start thinking about things like heart transplant. I'd love to hear your questions as we proceed. I want this to be as interactive as possible, so please use the Q&A feature, and we'll hopefully be able to address everybody's questions as we go along. And just in answer to Paul's question, I'm a huge Vancouver Canucks fan. I'm from Vancouver, British Columbia originally, and so I am a tortured hockey fan, as my team has never won the holy grail of the Stanley Cup, but there's always next year. So without further ado, let's talk about the heart failure epidemic. So we live in a world where more than 6 million adults in the United States have a diagnosis of heart failure. About 3 million have systolic heart failure, and about 3 million have so-called diastolic heart failure. Heart failure accounts for about 15% of the deaths in the United States each year. And in 2018, the estimated costs of taking care of heart failure exceeded $30 billion. And those costs are only expected to increase as we have an aging population with an increasing prevalence of the disease. Over 50% of those costs are driven by acute hospitalizations. And you can see on the bar graph on the right that primary hospitalizations per year in the United States for heart failure exceed all forms of cancer. So over 1.2 million hospitalizations in the year for heart failure. You'll understand as we go through this that our focus in treating heart failure is not simply focused on preventing death, but also to reduce the hospitalization rate for heart failure patients. Furthering the epidemic, a rise in cardiovascular risk factors, improvement in survival from ischemic heart disease, and aging population, all of these things have led to the increase in prevalence in heart failure. And we have terrific therapies for heart failure. I'm going to go through them in a little bit. But despite these innovations in medical therapy, survival's really only modestly improved since 2000. You can see the plot on the left side of the screen showing at the top changes in 1, 5, and 10-year survival following a diagnosis from heart failure. And you can see those lines are fairly flat. We really haven't made a huge dent in the survival. On the bottom, you can see that how you get diagnosed with heart failure really does impact your long-term prognosis. You can see that if you don't have a diagnosis of heart failure, what your 15-year survival might be. But if you get diagnosed during admission to a hospital, as opposed to not being admitted to the hospital, the prognosis is significantly different. And it's helpful, or when I moved back to the West Coast after being on the East Coast and living in Atlanta, where there was a ton of cardiovascular disease, I kept thinking, oh, I'm moving back to the West Coast where the prevalence of heart failure is going to be significantly lower. But if you look at that, the map on the right side of the screen, you can see that even in a relatively healthy part of the country, we have a huge burden of heart failure here in Oregon and in Washington. Heart failure is not localized to certain pockets. It is everywhere, and it requires aggressive treatment. You know, the interesting thing about heart failure is that when you have a diagnosis, it seems obvious, but it can be very challenging to diagnose. And unfortunately, almost 40% of patients with a new diagnosis of heart failure are diagnosed in the acute care setting, whether that's in the emergency room or after being admitted to the hospital. However, about 46% of patients have reported symptoms of heart failure to their physicians in the preceding 6 months. And remembering that last slide, if that diagnosis is made earlier, you can get them on treatment sooner and you'd greatly impact their prognosis. And so it's really imperative that we keep heart failure in mind when patients come in with certain symptoms. Now, how do you make a diagnosis of heart failure? I mean, it's not necessarily the easiest diagnosis to make. Is it simply based on symptoms? Is it ejection fraction? Is it risk factors? Do you have to check natriuretic peptides? What about exam findings or family history? There are a lot of factors that go into a diagnosis. It's not like cancer where you get a tissue diagnosis and you have your answer. It is a constellation of all of these factors that lead to making a diagnosis. So starting with symptoms, these are pretty common symptoms that people have. Shortness of breath, wheezing, coughing. I bet most of you see those symptoms in your patients multiple times a day. That doesn't necessarily mean they all have heart failure, but it's important to keep in mind that these are the most common symptoms that patients present. I can't tell you how many patients I've seen who have said, yeah, I was diagnosed with walking pneumonia, 3 months ago before their diagnosis, or I kept being told it was my asthma for so long, or, my doctor told me that it's because I have to lose weight and I'm just out of shape. Everybody's fatigued these days. 3 years of being cooped up inside without a whole lot of socialization. Everybody complains of fatigue these days. But some other subtle signs I think you need to keep in mind are early satiety or weight gain. Getting full really quickly is a pretty good sign for increases in abdominal edema and swelling of the edema in the GI tract. Feelings of palpitations could signal arrhythmias. So keep all of these symptoms in mind when you're evaluating a patient. Now, again, that doesn't mean that every patient with these symptoms has heart failures, but then you start to combine cardiovascular risk factors. Look at the prevalence of hypertension or arrhythmias or chronic kidney disease, amongst others. These are all things that you have to kind of piece that puzzle together to try and have a high enough degree of suspicion to then go on to the next step, which is doing some diagnostic testing. And what is the diagnostic testing? Well, really it comes down to the way I think about it is both an echocardiogram and natriuretic peptides. And we'll get into natriuretic peptides a little later in the talk. And I'm not going to go into detail about the echocardiogram. This is not an echo conference, but an echo is an essential part of making a diagnosis of heart failure. Obviously, if you get an echo and there's a reduced ejection fraction in the setting of those symptoms and risk factors, you have a diagnosis. But sometimes the squeeze is normal. The ejection fraction is normal, but there are other changes in an echo that can suggest diastolic heart failure. Changes in diastolic pressures, changes in atrial and ventricular sizes, hypertrophy of the myocardium. So these are all important things that we look at with an echocardiogram that makes it such an invaluable tool in making this diagnosis. And so that's kind of where we are at with making a diagnosis. You got to take the symptoms, you got to take the risk factors, take an echo, take natriuretic peptides, and put them all together to make this diagnosis. But it's also important to start thinking about what is the underlying cause of heart failure. Now, that's not to say that we necessarily treat various forms of heart failure different. The medical therapy that I'm going to start talking about in the next couple of slides is consistent across the spectrum of causes of heart failure, but it is also important to think about what is causing the the findings in your patient. Do they have a family history of heart failure, which would suggest a genetic etiology? Do they have cardiovascular risk factors like hypertension, diabetes, obesity, smoking that might make ischemic disease more prevalent? Or do they have findings on their echo of diastolic heart failure or heart failure with preserved ejection fraction, where we need to start thinking about things like infiltrative pathology, things like amyloidosis, sarcoidosis, or other diseases that are associated with infiltrative disease. And the reason it's important to make this, to start thinking about the etiology, again, it's not necessarily because the medical therapy is that much different, but there are certain interventions that we might consider for various etiologies. That's a little outside of the scope of what I'm going to be talking about, but just something as you are making these diagnoses on your patients that I want you guys to consider. So that's kind of the background on the scope of the disease and how we start thinking about making a diagnosis. Let's talk about treatment. So with when I came out of training, and really even before I was in cardiology, heart failure therapy centered around systolic dysfunction, and we had what we knew as triple therapy. We had evidence-based beta blockers, either metoprolol succinate, also known as Toprol XL, carvedilol, and bisoprolol. We had ACE inhibitors and ARBs, and we had aldosterone antagonists. For self-identified Black patients, there was one big study that showed the benefit of hydralazine and nitrates. And you can see that the guidelines in 2013, which is when I came out of training, these four therapies had class 1A recommendations, and you can see the relative risk of mortality reduction, the number needed to treat, and the relative risk of hospitalization reduction for those therapies. And that was medical therapy when I sort of became a heart failure cardiologist, so to speak. On the right-hand side, you can see what our therapies for HFpEF have been. Really, we had diuretics. We had no other therapy. This is a disease that affected half of the population with heart failure, and yet we had no real proven therapies other than diuretics to improve symptom control. In the last 10 years, we have gone through an extensive change in how we think about heart failure, not just in terms of how we add these medications, but also in terms of the options of medical therapy. And so I want to go through that. So around 2016, 2017, I call this the paradigm shift. And this is when the data for angiotensin receptor neprilysin inhibitors, also known as Entresto, came out. And it showed the superiority of Entresto over ACE inhibitors. And so this was the first new medical therapy for heart failure in well over a decade, if not close to 2 decades. And so quickly there was an update to the guidelines for systolic heart failure that recommended ARNIs either for de novo heart failure or to transition patients from ACE or ARBs to Entresto. You can see beta blockers and aldosterone antagonists remained with their 1A recommendation. And there was also some soft data supporting a reduction in heart failure hospitalizations for the use of ivabradine. Again, though, in 2016, 2017, we still had no new therapies for HFpEF. And then in the most recent iteration of the guidelines, back in 2022, last year, this was when we added a fourth limb to our medical therapy for systolic heart failure, the SGLT2 inhibitors, which most of you are probably much more familiar with than most of my cardiology colleagues, because SGLT2 inhibitors have been around since 2014 for the treatment of diabetes. However, in the last several years, we have a wealth of data, and I'm going to go through all of that, supporting the benefit of SGLT2 inhibitors for both systolic and diastolic heart failure. Over this time, some additional data has come out supporting the use of mineralocorticoid antagonists, or spironolactone and Entresto, in heart failure with preserved ejection fraction. And so our most recent updated guidelines, you can see, has evolved from where we were a decade ago. We still have the beta blockers, we still have the mineralocorticoid antagonists, but now SGLT2 inhibitors and ARNIs are both considered 1A recommendations, and you can see the data supporting them, the number needed to treat, and the mortality risk reduction. And you can also see we now have much more data supporting medical therapy for heart failure with preserved ejection fraction. So it's a really amazing state that we are in right now, where our therapy has really evolved, and I think we can treat patients much better and hopefully start making a much bigger dent in those mortality trends. I'm only going to spend a little bit of time on beta blockers and ACE inhibitors, because I'm assuming that these drugs have been around long enough that I don't need to share the original trial results with you. But what is really important, the thing that I want you guys to really take home, is not just that these medicines work. It's that these medicines work when you get them to their optimal doses, which is the highest dose possible. You can see the data on the left-hand side of the curve, on the left-hand side, showing the benefits, the mortality benefits of higher dose ACE inhibitor versus low dose ACE inhibitor. And similarly, you can see on the right-hand side, this is data for carvedilol, that at higher dose, you have a lower mortality and you have an increase in ejection fraction. And so it's one thing to put patients on these medications, but what you have to do is you have to get them up to the optimal doses of these medications. I think that's one of the biggest things that I see, is that, and it's not just primary care, it's also with cardiology. It's that patients get put on these therapies and they feel fine, and then nothing has changed. You know, the idea of don't rock the boat, but really you're doing your patients a disservice if you're not pushing these doses to the maximal possible dose every time you see them. And so when I see patients in clinic, I see them back every couple of weeks, and each visit we titrate up the dose, even if they feel well, because there's benefit to getting to highest dose. All that said about ACE inhibitors, we have really transitioned away from ACE inhibitors for most patients and switched them to angiotensin receptor neprilysin inhibitors. This is Entresto, and this is based on the Paradigm heart failure trial, which randomized patients on optimal medical therapy with beta blockers, mineralocorticoids, and ACE inhibitors to either enalapril or to Entresto. They randomized 8,400 patients with ejection fractions less than 40%, and all patients were NYHA class 2 to 4. That means functional class 2 is mild symptoms. These are the patients who walk into clinic and probably tell you that they feel fine. They don't really have any exertional limitations except when they are really pushing themselves. So carrying a couple of bags of groceries in from the car, they might get a little winded. Going up a couple of flights of stairs, they're going to get winded. But generally doing their ADLs, they feel fine. As opposed to a functional class 4 patient is somebody who has symptoms at rest. So after randomizing them to Entresto or enalapril, they were followed for, on average, about a little over 2 years, 2.5 years. And the study was ended early because of the superiority benefit of the Entresto group. And you can see there was a 20% reduction in cardiovascular death, a 20% reduction in the combined endpoint of cardiovascular death or heart failure hospitalization, and a 21% reduction in heart failure hospitalization. All of that led to a number needed to treat to reduce one primary endpoint, the combined endpoint of 21 patients. And the goal of the study was to get people on the highest dose of Entresto, so 97/103. So again, in the study design, it was mandated that you titrate the drug to the highest dose. Now, there are some side effects associated with Entresto. It can definitely lower the blood pressure. It works via the kidneys, and so you can see some changes in creatinine. But by going slowly with your titration and monitoring lab parameters and seeing your patients relatively frequently to make sure that they're not exhibiting any of these side effects, you can get patients on maximal dose and thereby realize the true benefit of these medications. Further data has come out supporting the benefit of angiotensin receptor neprilysin inhibitors in the Pioneer trial, which looked at changes in natriuretic peptides when patients were started on Entresto in the hospital. And so what they showed was this is generally decompensated patients starting on Entresto versus enalapril. And in 6 weeks, they saw a larger and sustained reduction in NT-proBNP. NT-proBNP being one of our better markers for assessing risk. And again, I'm going to talk about that a little later in my slides. But basically, this was a good surrogate for a short-term study suggesting A, Entresto is safe to start in hospitalized patients, and B, that the benefits suggest in the short term, benefits in the short term are there. And then when these patients were followed for an extended period of time, an extension part of the Pioneer study showed that cardiovascular death and readmissions at 8 weeks were reduced by 42% when Entresto was started in the hospital. And during the open label extension study, that was continued all the way out to 12 weeks. So the takeaway is that Entresto is safe to start early and should be continued long term if you can. I think it's useful to stop and just kind of give some personal insights about Entresto, or RNAs as I call them. First off, I think the data support shows that Entresto is superior to ACE or ARBs. It's not just that it's equivalent. I think Entresto is a better drug. That doesn't necessarily mean that every patient can and should be on Entresto, but if your patients are on an ACE or an ARB, you should transition them onto Entresto. Like I said, the Pioneer trial showed that inpatient initiation of Entresto is safe. And actually, on some post hoc analyses, the magnitude of benefit of Entresto is even bigger for less symptomatic patients. So for NYHA2 patients versus 3 or 4, and in patients who have not previously been hospitalized, the magnitude of benefit long-term is actually greatest. So that patient who has never been hospitalized for heart failure, who walks into your clinic and says they feel fine, that's exactly the patient who you need to be switching to Entresto. Generally, Entresto has some diuretic effects, and so it's better to start Entresto when your patient is a little fluid long. And if they're euvolemic or dry on exam, I often recommend decreasing their loop diuretic dose. And generally, because it affects the blood pressure, you start low and you titrate up. It's okay to use once a day, even though it's a twice a day medication, if you're getting your patient acclimated and if they have relative hypotension to start. Sometimes I also have them split pills. Again, better to start them as low as possible and work their way up once their body has acclimated, as opposed to starting too high. They get hypotensive, they get acute kidney injury, and then you may not be able to get them on it again because they're kind of scarred from that. Generally, if your renal function is okay, is good enough for an ACE or an ARB, it's good enough for Entresto, and it's usually well covered by most insurance. Most Medicare plans charge less than $100. And you should expect a rise in BNP on Entresto, but not NT-proBNP, because it's not affected by the sacubitril component of Entresto. So I've taken to just checking NT-proBNPs as opposed to BNPs for my patients on Entresto. Typically, I check renal function every 2 to 4 weeks after a dose adjustment. I'm going to change gears and talk about the new class of medication called an sodium glucose cotransporter 2 inhibitors, SGLT2 inhibitors, that have really come on in the last 2 years for the management of heart failure. So we have 2 big clinical trials looking at heart failure with reduced ejection fraction. The first one looked at dapagliflozin, called the DAPA-HF trial. Similar to the Entresto trials, it took patients on optimal medical therapy who were functional class 2 to 4, who had features of high risk, whether a recent hospitalization or an elevated natriuretic peptide, and randomized them to dapagliflozin 10 milligrams a day or placebo. And again, a combined endpoint of cardiovascular death or heart failure hospitalization was reduced by 26%. And the components of that primary endpoint were also equally reduced in a significant fashion. Similarly, with the Emperor Reduced trial, which looked at empagliflozin, similar trial design, similar patient population. This is all in patients with ejection fractions less than 14%. And you can see a similar, if not slightly improved, reduction in primary endpoint. The follow-up of this study was a median duration of 16 months. So we're not talking about very long trials to see this magnitude of benefit. One of the things about Emperor Reduced, we should probably get a new label indication pretty soon, is that they looked at a renal outcome, and they showed that in patients with heart failure who were treated with SGLT2 inhibitor, with empagliflozin, there was a 50% reduction in composite renal outcome. So that included worsening renal function, ending up on dialysis, or sustained reductions in eGFR. So you're actually providing renal benefits, renal sparing effects with the SGLT2 inhibitors. And actually that is one of the things that leads to a lot of the worsened outcomes in heart failure, is the progressive renal dysfunction that we do see. And so SGLT2 inhibitors not only improve heart failure outcomes, they also protect kidneys. I will get to some of the data in HFpEF in a little bit, but some of the clinical pearls that I have for SGLT2 inhibitors is that there is a likely class effect. So generally the data for DAPA or EMPA is similar, and I typically use whichever one is covered by insurance. There is no heart failure data available for canagliflozin though. We suspect it's probably the same, but the trials just haven't shown that or haven't been done. The benefit of SGLT2s in these studies, the significant difference in outcomes became apparent within 3 weeks after randomization. No other medical therapy has shown a statistically significant benefit that quickly in randomized controlled trials. So within 3 weeks, patients realized the benefit, and anecdotally, I will say patients feel better when they get put on this medication. They have less dyspnea, they have less heart failure symptoms, and they just have more energy. And so the sooner you start them on an SGLT2 inhibitor for their heart failure, the better they're going to feel, and the better they're going to, their better outcomes they're going to have long term. It does not matter if you start an SGLT first or fourth when you're thinking about guideline-derived medical therapy. The order of initiation doesn't matter. Typically, the major adverse effects include genital and urinary tract infections, and there is a small risk of DKA in patients, so you do have to be mindful of that. I don't see a whole lot of blood pressure lowering effect, except in patients who are too dry. Again, like Entresto, SGLT2 inhibitors have a diuretic-like effect. And so if patients are already dry and you don't change their diuretics or other medications, they may get hypotensive. Usually no adjustments to diabetic regimens are needed, even those on insulin, because SGLT2s don't typically affect insulin secretion. So most endocrinologists who I've talked to don't feel that for the vast majority of patients, no adjustment to their other diabetic regimen is required for those who do have diabetes. Typically, I check a renal function panel a little later than I do for Entresto. I usually wait about 4 to 6 weeks. You will see a slight bump in creatinine early on with sodium glucose transport inhibitors. This is expected. It's not a reason to be concerned or to change therapy. So I recommend checking it about 4 to 6 weeks after you start it, because that's about the time when kidney function should return back to baseline. And the other thing to keep in mind is with diabetes, the GFR cutoff for SGLT2 inhibitors has been 30 or higher. You can use it, but for heart failure, the trials enrolled patients with GFRs as low as 20. And so for a heart failure indication, you can use the GFR cutoff of 20 or above to start therapy. So as we discussed, in 2010, medical therapy for heart failure included beta blockers, ACE inhibitors, MRAs, and I include ICDs, CRTs here. However, back then, you can see only about a small fraction of patients were on optimal medical therapy. You know, with beta blockers, about a little over a quarter of patients were on optimal doses of beta blockers, maybe about 30% on optimal doses of ACE or ARBs, and a little bit more on MRAs, because typically those don't need to be titrated to a target dose. But even in 2021, we haven't seen much benefit in terms of getting patients to target doses. And I think this is actually one of the major reasons why mortality rates have not changed over the last decade or two. Because yes, we have these great therapies. They all reduce cardiovascular endpoints, mortality, and hospitalization, but we are not treating our patients to the appropriate doses and with the appropriate medications, you know, despite having all of these tools in our tool belt. And so typically the way I was trained was the way we add medical therapy was you start with an ACE or an ARB, you titrate that dose, that medical therapy, that medicine to a maximum tolerated dose, then you transition to an ARNI, then you titrate that, then you add a beta blocker, then you titrate that, then you add a mineralocorticoid antagonist. I think of this as like laying bricks on top of each other. And it was slow, and it resulted, I think, as you can see from that last slide, that most patients didn't end up on triple therapy and didn't get to maximum doses. We have changed our way of thinking about this, and there is now a lot of pushing to, from a quality standpoint, to start making it so that we start looking at how quickly are you getting patients on quadruple therapy. So instead of starting one and titrating it up to the maximum dose and then starting another and titrating it up, you start all of the medical therapy at low doses right from the get-go, and then you start titrating the ones that need to be titrated, the ARNIs and the beta blockers. I think of this as laying a better foundation for your heart failure patients and then getting them up to the maximum doses. There's a lot of benefits to doing it this way. For one, when you're starting therapy for a patient, usually they're symptomatic, and these medicines will make them feel better. Once they feel better, they're going to be less resistant to adding more medical therapy. And so if you get them on all of the meds when they're not feeling their best, they're going to be more likely to stick with it. And there's also, I think, a benefit long-term of blocking the various neurohormonal pathways that cause the pathophysiology of heart failure and the long-term problems, the mortality and the long-term complications of heart failure. There is a benefit of blocking those pathways, even at low doses, right from the get-go. So instead of blocking one pathway fully and leaving the other pathways unattended to, you get blockade of all of the pathways at some degree right from the beginning, and then you can titrate up and realize the benefits of medical therapy. And so for systolic heart failure, you can see the 2-year mortality with no medical therapy is close to 35%. And if you add all 4 therapies, you can reduce the relative risk of mortality, of 2-year mortality, by 73%, and an absolute risk reduction of 25%. That's 4 patients to reduce a mortality when you treat them with quadruple therapy. Put it another way, if you treat your heart failure patient with maximal medical therapy, you're adding 8 additional years free of cardiovascular death or hospitalization, and 6 additional years of overall survival. So really, you're doing your patients this benefit by pushing the medical therapy. Okay, enough about systolic heart failure. I'm going to transition to diastolic heart failure, which is something that for a long time we really didn't have any treatments for. I'm going to talk about spironolactone. So there was a trial called the TopCat trial, which looked at ejection fractions greater than 45% who have previously been hospitalized and randomized patients to placebo or spironolactone, 45 milligrams a day, and looked at the relative outcomes of composite death from cardiovascular causes, hospitalizations, and aborted cardiac arrest. This was a global trial done in the US, South America, as well as Russia and Georgia. And what you see is that these slides are small, or these curves are small, but there's no benefit. Spironolactone was considered a negative trial. This was back in 2014. However, when they did some post-hoc analyses, they found a very interesting thing. They found that the outcomes of patients who were treated in the trials differed based on regionality. So you can see that the primary outcome in patients who were treated in the Americas had a vastly different curve than those treated in Russia and Georgia. Same thing for hospitalization, same thing for cardiovascular death. And when you actually break it out for those randomized to placebo or spironolactone in the Americas, you get a statistically significant benefit of spironolactone. And when they looked at the patients treated in Russia and Georgia, the effect of spironolactone was very different than those treated in the Americas. They didn't have a blood pressure lowering effect. They didn't see any signs of rising potassium, things that you would expect to see in patients treated with spironolactone. So it's unclear if those patients were truly treated or how they were treated. But the reality is this data supports the notion that something was very different in the patients treated or randomized in the Russia-Georgia part of the world versus the Americas. Now, this is not definitive. This is certainly hypothesis generating, but it does suggest that there may actually be a benefit for spironolactone in our patients with heart failure and preserved ejection fraction. Again, when you look at the primary outcome in patients in the Americas, you can see these curves. The benefit seems to benefit patients with ejection fractions of 40 to 60% in terms of reducing hospitalization, reducing cardiovascular death. And so there is a new trial looking again at spironolactone in heart failure with preserved ejection fraction that is currently ongoing. So hopefully we can clarify this data. I will say in my practice, I use spironolactone quite a lot for patients with HFpEF because typically the patients that I see are those who have been hospitalized, who are symptomatic, who have elevated natriuretic peptides. I consider these higher risk patients. And so I use spironolactone because I think the data supports at least a suggestion of a benefit. So I use spironolactone a lot in treating patients with heart failure with preserved ejection fraction. Similarly, I use Entresto in patients with preserved ejection fraction. So Entresto was studied in the CareOregon trial, again, looking at patients with ejection fractions 45% and above and elevated natriuretic peptides and randomized them to valsartan or sacubitril valsartan and looked at the composite of heart failure hospitalizations or death. Now, Entresto missed its mark by a fraction. You can see that the Entresto group did have a trend towards a lower composite endpoint and a lower hospitalization for heart failure, but the p-value was 0.06. Again, nothing that you can draw a definitive conclusion for, but a trend towards a benefit. And in patients, again, who I see who are somewhat symptomatic, who have been hospitalized, who have elevated natriuretic peptides, I think the data is justifiably good enough that you can try treating patients with ARNIs. And again, post hoc analyses do suggest on these slides, and the slides will be sent out later so you can look at them a little bit more in depth, that as you go from an ejection fraction of 40–45% all the way up to about 60, there does seem to be a benefit of Entresto. Once we get above 60%, probably not, but generally in the 45 to 60%, there seems to be some benefit, and that's where ARNI's got a 2B indication, which suggests that it might be beneficial in some patients. On to the SGLT2 inhibitors. So this is finally a trial where I don't have to try and convince you that the benefit is there. This is a trial that truly showed a statistically significant benefit in patients with HFpEF. So this trial was the Emperor Preserve trial. It took patients greater than 18 years or older, ejection fractions greater than 40%, and elevated natriuretic peptides, and randomized to empagliflozin 10 or placebo, much like the Emperor Reduce trial. And what they showed was a statistically significant benefit, a 21% relative risk reduction in the primary endpoint with a very significant p-value, and an absolute risk reduction of 3.3%. So it's the first trial to ever show a statistically significant primary endpoint in HFpEF patients. And you can see those curves, they're separated early on. Again, I mentioned it before, but the curves separate within 3 weeks. And so the benefit of SGLT2 inhibitors is from the get-go, and especially the heart failure hospitalizations, those curves are still separating. So you can see a dramatic reduction in hospitalizations for heart failure as time goes on. Similarly, the DELIVER trial looked at dapagliflozin in a very similar population, and you can see a very similar reduction in cardiovascular death or worsening heart failure. So we have 2 trials now showing a statistically significant benefit of SGLT2 inhibitors in heart failure preserved ejection fraction. So absolutely, this has to be your first line therapy when you're treating a patient with HFpEF. With or without diabetes, SGLT2s are what we start right from the get-go. And I'm sure the next iteration of guidelines will change the 2A designation to a 1A designation now that we have multiple clinical trials showing benefit. So that's a whirlwind through the data on the medical therapy. How do you monitor a patient? You're seeing them in clinic. What are you looking for? Well, there have been a lot of studies trying to figure out what the right things to look for in exam and in terms of symptoms are for patients. What I would suggest to you is that edema is not a particularly good sign. Most patients don't necessarily present with edema. Weight gain is a flawed metric. You can see some of the odds ratios for certain physical exam findings and signs that suggest a diagnosis of heart failure. What I find to be the most useful physical exam finding is elevated neck veins. If you have elevated neck veins, it suggests congestion. It almost clinches a diagnosis of heart failure for me. Other things to think about: elevated heart rate might suggest a lower cardiac output, and it's compensating. Rails can be present, but it can also not be present. Presence of AFib or an irregular pulse is often coexistent with heart failure, and obviously a displaced apical impulse suggests an enlarged cardiac enlargement of the cardiac size, and so it could also suggest heart failure. So you've got a physical exam finding suggestive of heart failure. You've got you've got symptoms suggestive of heart failure. What about other things that you can use from a diagnosis or a monitoring standpoint? And so I use natriuretic peptides all the time. I'm a huge fan of them. from a diagnostic standpoint, they can be really helpful in distinguishing whether your patient with shortness of breath is having it from heart failure or some other cause. And you can see the data showing that the negative predictive value of a BNP that is less than 80 or 100 is really great. So if you have a low BNP in a patient with shortness of breath, it's very unlikely to be heart failure. Conversely, if you have a BNP greater than 100, you have a very good sensitivity and specificity that it's highly suggestive of heart failure. It's not diagnostic, but when you put it together with your signs, your symptoms, and maybe an echocardiogram, it's a very useful tool. However, not all natriuretic peptide results are the same. And so you have to understand that baseline normal values of BNP differ based on a lot of different functions or different factors. So in patients who don't have heart failure, who the normal ranges of BNP were formulated for, you can see they should not have elevated natriuretic peptides. However, in patients who have LV dysfunction, a normal value of BNP is probably going to be closer to 300 or 400. So an elevated BNP in somebody who has a diagnosis of heart failure is not necessarily the same as a normal BNP in somebody who doesn't have heart failure. And a normal BNP is going to change based on symptoms. That doesn't necessarily mean that their heart failure is getting worse, but you just have to keep in mind that renal function, symptomatic heart failure, degree of LV dysfunction, all of these change the normal value of BNP. And so it's not necessarily the same. And so like I said, I check BNPs all the time. And I often get messages from my patients to say, hey, my BNP, I check NT-proBNPs, and they send a message to me, my NT-proBNP came back 800. What does that mean? And that's actually normal for somebody with systolic dysfunction who's doing reasonably well. In fact, there's a trial looking at what is the prognostic utility of natriuretic peptides, and they looked at outcomes based on patients with NT-proBNPs greater than 1,000 or less than 1,000. And you can see the lines in red are those who have NT-proBNPs less than 1,000. And so if you're less than 1,000 with heart failure, your risk of mortality and cardiovascular death and hospitalization is much lower than if it's greater than 1,000. And so this is how I kind of use it from a prognostic standpoint. So you've got your BNP, you've got your symptoms, you've got your exam findings. How does the echo help you? Well, echo can be obviously useful in making a diagnosis. If you've got a low ejection fraction, you've made a diagnosis, but it can also really be helpful from a prognostic standpoint. And it's not just about the ejection fraction. We talk about ejection fraction all the time. Patients love to know what their ejection fraction is, but it is far more, there is so much more information from an echocardiogram, and the ejection fraction is just one piece of the prognostic puzzle. And you can see this CART analysis using echocardiogram, all of the different tools, and you can see the top line of ejection fraction less than 22% or greater than 22% really only changes your mortality prediction by a little bit. When you start adding in all of the other things that you gain from an echo, whether it's RV function, size of the ventricle, strain patterns, filling pressure assessment, these are all very useful in helping to fill in your prognostic assessment. Now, I'm not suggesting you guys are going to become, echocardiographers overnight, but just know that the echo is far more than just an ejection fraction measurement, because ejection fraction is variable. It changes with medical therapy. It changes with certain insults. It can change with AFib or sinus rhythm, amongst other things. And so it's not only about the ejection fraction. It's really about the whole picture. And this is what I try and educate a lot with my patients, that it's not simply that number, even though we all talk about it. So before I'm done, I want to briefly touch on advanced heart failure. This is where I see most of my patients, but it's not necessarily the only thing that we manage. So we have subclassified patients into different stages of heart failure from A through D. A being patients who are at risk for heart failure but do not have structural heart disease. B is patients who have structural heart disease, so they have a change in ejection fraction, but they have no history of signs or symptoms of heart failure. Stage C is where most patients live. They have structural heart disease and they have had or have currently symptoms of heart failure. And stage D is really end stage refractory heart failure. Once you advance to a certain stage, you do not go backwards. So once you are in stage C, you do not go back to B or A. Once you are in D, you do not go back to C. We also classify patients' symptoms. I mentioned this earlier from 1 through 4. So 1 is no symptoms, 2 is slight limitations, 3 is moderate or marked limitations, and 4 is basically symptoms at rest. And then when we get into the advanced heart failure, we talk about intermax profiles. And I won't bore you about what the intermax profiles are, but we classify them from 1 through 7. And it's useful so we all speak the same language, that it's useful from a prognostic standpoint and from a sort of discussion standpoint. You may have seen a slide like this when talking about heart failure progression. What this tells you and what this is useful to show to patients is that usually when patients get diagnosed, they're symptomatic, and you can see the initial curve as we progress over time with quality of life decreasing when they get diagnosed, and then they get treated and they get put on medical therapy. And then there's usually a plateau phase of heart failure where you're compensated, you're on medical therapy, your quality of life is good, you have minimal symptoms. However, as heart failure progresses, it's often typified by peaks and valleys of symptomatic recurrences of heart failure. And the key to understand is when you get symptomatic, when you have a decompensation event, you can get treated, you can get diuresed, you can be optimized with medical therapy, but often you don't get back to that same level of quality that you had prior to your decompensation. Now, if we push medical therapy harder than we did before, if we optimize patients, maybe we can, but typically heart failure progresses and it's typified by these peaks and valleys, and the peaks never get as high as they previously were. And then we get into the end stage or the refractory phase, and that's where we need to start thinking about palliative care, advanced heart failure therapy options like a transplant or an LVAD. So from your standpoint, how do you know when a patient is advancing to heart failure? Well, sometimes you just know. You know they've been hospitalized multiple times, but there's a useful acronym that I think is helpful to keep in mind, and it's called I need help. And it's just a series of things to look for that might suggest that the patient is getting worse. So inotropes. Have they needed inotropes during a hospitalization? NYHA class or natriuretic peptides. So are they persistently class 3 or class 4? Do they have an NT-proBNP greater than 1,000? End organ dysfunction. Do they have signs of worsening kidney or liver injury? Ejection fraction. Are they persistently less than 20%? I know I mentioned that ejection fraction doesn't really hold tons of sway, but if they are persistently really, really low, that is a bad prognostic sign. D, are they getting defibrillator shocks? H, have they been hospitalized? Or are they hyponatremic? Typically, a sodium value less than 134 is a very poor prognostic sign, and it suggests an advanced stage of the disease. E, edema or escalating diuretics. Are you getting a ton of phone calls from your patients that they have persistent swelling, they have more shortness of breath, and you're just going up and up and up on their Lasix dose? That is a bad sign, and it suggests that they may be entering a worsening phase of their disease. L, are they persistently low blood pressure? Now, I typically keep my patients' blood pressures in the 90s over 60s. On optimal medical therapy, that is a normal blood pressure for a patient with systolic heart failure. However, are they dipping even lower than that? Are they getting lower than what they normally experience? And P, prognostic medication. So are you having to down titrate or withdraw their medical therapy because of low blood pressure, because of symptoms, because of renal dysfunction? Yes, you may make them feel better in the short term, but if you have to stop an ACE inhibitor or an ARNI, if you have to stop a beta blocker, these are bad prognostic signs. And it's that time where you need to think about talking to your patients about the fact that their heart failure is getting worse. And if they haven't seen a specialist for this, that's the time, if not sooner, to make a referral to myself or one of my, another heart failure program to get them evaluated for either clinical trials, advanced therapy options, or even to just have a palliative care discussion about their prognosis. And with that, I thank you for your time and attention. And I'm happy to answer any questions in the Q&A session a little later on. I hope this wasn't too whirlwind a trip down heart failure lane. Thank you.
Dr. Remick, that was fantastic. I cannot express what a fan I am of people who are able to cover such a wide range of incredibly detailed clinical information, yet somehow maintain this super high engagement level the whole time and make it accessible. I mean, you can tell when someone's a natural educator. And Dr. Remick, I have to say that you are, my friend. So incredibly well done. I think the folks are really going to benefit from this. It's amazing how many new things have just come out in just a comparatively short amount of time. Just from where we were 10 years ago to where we stand now. It's super encouraging to see what's coming up. So really, really great.